I think that, the lesson with these two studies is something that Mike mentioned earlier, is that we got the dose wrong for all of these drugs for frontline. In SND, fortunately it was tested directly in that same study, and the dose for salvage is one, the dose for frontline is lower, and it's equally effective, and of course makes it safer. In the bosutinib, we have these two studies, and the lower dose ended up being better. With dasatinib, we didn't have that information, but now this recent study shows that lower doses will be more effective. So certainly in the frontline setting, looks like a lower dose could be
I feel obliged to say something. And that is the dose of the nilotinib. I agree with you that 300 appeared to be better tolerated than the 400, and definitely true in terms of cardiovascular events. There were more cardiovascular events in that 5-year update with the 400 twice daily. But what I am just intrigued by is that although numerically it didn't seem like much, actually survival was statistically better with 400 twice daily of nilotinib versus imatinib 400.
Survival was, but MR4.5 and sustained MR4.5 was not. So, we need to see what the reasons for the cause of death and all these things were. But these other, the cumulative curves of MR4.5 and the sustained MR4.5, they're pretty much the same.
The reason I bring that up is that in my mind it brings up something that we should be considering, and that is, what is the best approach? So we've heard about in terms of extending survival, maybe getting to a treatment-free remission. Do we, and we've all heard this, do we start with imatinib and then move to a second generation, or do we start with our best second generation drug, that most effective drug, up front in the first year, especially when there's the highest risk of progression, and then go to lower doses or imatinib? And I think we're all struggling with that. There's no good answer there.
We haven't really done the induction and maintenance approach study.
We need to be like AML doctors, right?
Well,
no?
I think it's a fact. It's based on the fact that the TKIs are very well tolerated.
Right.
So there's hesitancy, but you're right. You bring a great point.
But I think the good thing here is that we're talking about kind of splitting hairs. We have many very good approaches in CML.
Absolutely.
So we're very fortunate that we can have this conversation because we have so many good approaches that we don't even know these subtleties because they're so hard to dissect with these good therapies.
So we brought up the the cardiovascular toxicities that we're seeing in the NEST-ND study, but what are your opinions about whether the cardiovascular risks, the arterial occlusive events, are those, is that a class effect, or is there really a difference between the second generation drugs, one from each other, or is it just them versus imatinib?
I think we still don't understand the mechanism of action. There are some observations. I think we start methodically trying to unravel it by looking at metabolic derangements and risk factors. What do people look like? We know that typical patient with CML is going to be someone with comorbidities. Over half of patients do have cardiovascular comorbidities. We know that we can see metabolic shifts with change in blood sugar, change in lipids, nilotinib, as well as potentially there can be some things that could shift with other TKIs. When you look at meta-analysis, I think some drugs have more risks than others. My feeling is that many CML patients just need very good general medical care around their CML because CML perturbs a lot of things. And risk stratification of people, cardiovascular-wise, and managing those risks up front is, I think, required and is probably not done as much as we should. And then with, I think, careful assessment, we will hopefully unravel what could be the subtle differences. Maybe it may not be necessarily on the therapy side. It may be on the patient side. There may be factors that we could tease out to say this is a patient with greater risk than another. So I think a lot of research is still needed. But there are differences. They may differ from drug to drug. There are different toxicities in different organs. There's clearly vascular effects, for example, with dasatinib, but in the cardiopulmonary space rather than the general arterial system. And I think we could do a lot, basically, by just risk stratification intervention based on cardiovascular guidelines, which may not be our job, may be a job of cardio-oncology or collaboration with internal medicine. I think that's an important specialty that's arisen, which really is a boon for us. And I think we're starting to see some of the trials look a little bit more carefully at these questions.
Part of the problem with addressing your question is there's no comparison, direct comparison between the second generation TKIs. They've never been compared efficacy-wise, and certainly because of that, safety-wise. So it's very hard to assess. But with that caveat, my opinion is that this is a class effect. I think it is definitely something that you see with all the TKIs to a greater or lesser extent. So this came up initially with ponatinib, and I think it is fair to assume that ponatinib perhaps has the highest risk. Now, part of the problem with that is that we understand there are several factors that contribute to this risk. Mike mentioned the comorbidities and the risk factors, and we know that these events happen significantly more in patients that have these comorbidities, hypercholesterolemia, diabetes, obesity, all these things. But that's a large percentage of the U.S. population. So it's not like, well, you don't use it in those patients. Well, then don't use it in a lot of patients. So that is number one, but it tells us that we need to be careful in managing those things. We have not been careful. We have been, high-fiving because the PCR is 0.0 whatever, and ignoring a blood pressure of 200 over 120. Well, we cannot do that. So that's number one. But the other one is there's other elements. For example, the dose. We've learned that the dose matters. And the most direct evidence is from an SND, which you mentioned earlier. The risk is higher with 400 twice a day than with 300 twice a day. And when we looked at the ponatinib data, when you lower the dose, the risk went down. And so it does appear that to some extent the dose has something to do with that. We've done a comparison in our institution of all the, part of the other, before I get to that, part of the other problem is that when you see the reports from the different studies, it's very hard to assess because you don't know exactly what's being reported. Are they giving us myocardial infarction and angina, or are they telling us also about, I don't know, chest pain and these things like that? And it's very hard to assess what exactly is being included, which makes these comparisons different. But there's two things that I think we can determine. Number one, we don't have direct comparisons, but we do have in all of them comparisons with imatinib. So we can see the deltas between the different studies. And it is clear that that very brief study with ponatinib had the highest risk. But the deltas with imatinib or nilotinib and dasatinib appear similar, at least for cardiovascular and cerebrovascular, and much smaller for bosutinib. We also did an analysis, as I was telling you, in our patients that we treated frontline with all these TKIs in prospective clinical trials, single institution, they're not randomized. But then we went and looked at all these patients, all the SAEs that were reported in the study, all the A's and all these. And we find that we even had a frontline study with ponatinib briefly, was stopped. But we do have that, which is sort of like a control there. And we do see that risk is significantly higher with ponatinib. Dasatinib and nilotinib come pretty close together, and then imatinib lower. So I think that it is a class effect. There's a bit of a gradient there. We don't have a bosutinib study, so hard to place it somewhere in there. I don't think imatinib is protective. I think it's baseline.
Yeah. I agree with that too. I think it is a class effect for the second generation drugs, and the reason why we can't compare these studies in terms of cardiovascular risk is different doses that might be affecting that toxicity, different way of collecting those adverse events on the different clinical trials. You mentioned this in your oral presentation a couple of days ago. Different lengths of time that patients are on these drugs will affect the number of events that we are collecting, and we haven't actually seen the data in terms of patient years of exposure yet. So all of these things are important. I think the message I'm hearing from this panel is that in our patients on ABL TKIs, especially the second generation drugs, where they're living longer, we need to pay attention to this either ourselves or with partnership with their
Absolutely.
PCPs and internists.
It's
Very important.
it's a really good problem we have.
Yes. Okay.